Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Association of KRAS G13D Tumor Mutations with Outcome in Patients with Metastatic Colorectal Cancer Treated with First-Line Chemotherapy with or without cetuximab by Sabine Tejpar et al. My name is Wells Messersmith, and I'm a professor and director of gastrointestinal medical oncology at the University of Colorado Cancer Center in Aurora, Colorado. My oncologic specialty is medical oncology, specifically gastrointestinal cancers. Currently, in the package insert for cetuximab, a monoclonal antibody targeting the epidermal growth factor receptor, patients whose tumors harbor codon 12 or 13 KRAS mutation should not receive cetuximab. That is, KRAS mutations are a negative predictive biomarker for cetuximab. The central question this article addresses is whether KRAS mutations in colorectal cancer should be considered as a single entity or split out among the various particular mutations with regard to benefit from cetuximab treatment. Specifically, a codon 13 mutation located on exon 2 of the KRAS gene is postulated to behave differently compared to the more common codon 12 KRAS mutations. In this mutation, aspartic acid is substituted for glycine in a portion of the KRAS molecule known as the P loop, necessary for deactivation of KRAS. Since glycine is the only amino acid without a side chain, the theory is that another amino acid, such as aspartic acid, sterically inhibits the ability of KRAS regulators to turn off its activity, thus leading to constant activation of KRAS activity in signaling. The hypothesis that codon 13 mutations are different from codon 12 mutations stems from several lines of evidence. First, codon 12 mutations are found in other cancers, such as pancreas and lung cancer, but codon 13 mutations are found primarily in colorectal cancer, especially in cancers with defective DNA mismatch repair. Second, cell lines with codon 13 mutations grow less aggressively than those with codon 12 mutations in the laboratory. And in preclinical models of colon cancer, some tumor xenografts with codon 13 mutations are sensitive to cetuximab, whereas codon 12 mutant tumors are resistant. Finally, the Tejpar group reported in 2010 a pooled analysis in which 579 tumor samples were tested from 7 different clinical trials of cetuximab in chemorefractory colorectal cancer, including CO.17, Bond, Everest, and others. In that analysis, patients with G13D mutant tumors treated with cetuximab had improved overall survival and progression-free survival compared to patients with codon 12 mutations. In other words, the patients who had tumors with codon 13 mutations responded similarly to wild-type patients. This has led to a critical question. Should the package insert of cetuximab be changed so that patients with codon 13 mutated tumors are combined with KRAS wild-type patients and receive cetuximab? Many of these same questions are applied to another EGFR targeting monoclonal antibody, panitumumab, which has the same recommendation to avoid use in codon 12 or 13 mutant colorectal cancer. To test the hypothesis that previously untreated advanced colorectal cancer patients with tumors harboring G13D mutations treated with cetuximab have similar outcomes to KRAS wild-type patients, the authors obtained updated data sets from 2 first-line advanced colorectal cancer trials, Crystal, in which patients were randomized to FOLFIRI plus or minus cetuximab, and OPUS, a randomized phase 2 study of FOLFOX plus or minus cetuximab. In these studies, 1,535 samples were submitted for EGFR immunohistochemistry, an example of a biomarker being prematurely used since EGFR staining does not predict efficacy. And these samples were analyzed for KRAS mutations retrospectively. The primary objective of the study was to examine interactions between treatment effect and KRAS mutational status. The authors found that 39% of the patients harbored KRAS mutations, and of these, 16% were G13D. This prevalence is consistent with previous studies. In the G13D subgroup, treatment with cetuximab significantly improved median progression-free survival by 1.4 months with a hazard ratio of 0.47, and response improved from 22% to 40%, which is an odds ratio of 3.38. There was no difference in overall survival. Interestingly, G13 patients seem to do worse with chemotherapy alone compared to patients harboring codon 12 mutations, which points to complexities in these chemo combination studies, since it is difficult to tease out effects from one agent versus another, not to mention potential prognostic effects independent of chemotherapy. There are a few statistical issues that bear mention. First, according to the manuscript, the difference in progression-free survival and tumor response was noted, quote, after adjusting for differences in baseline variables, end quote, which can be problematic in retrospectively analyzing data from randomized studies. Second, according to the traditional metric of hazard ratios from forest plots that we are accustomed to seeing in oncology studies, the difference in progression-free survival for G13 mutants is not statistically significant, i.e. the confidence intervals cross 1. To demonstrate statistically significant differences, the authors use likelihood ratios, which allow the testing of multiple coefficients at once. However, the authors make very responsible, conservative conclusions from the study, noting that further data is needed prior to making any changes to current recommendations in the package insert for cetuximab. What about panitumumab? Dr. Mark Peters presented data from several panitumumab studies at the GI Cancer Symposium in January 2012 and found different results even for patients in the control arms of the chemotherapy only, where G13 patients were equivalent to other subsets. In addition, G13 patients treated with panitumumab fared no better than patients with other KRAS mutations. For comparison, Dr. Peters showed forest plots for cetuximab studies included in the present manuscript, Crystal and Opus. Since the confidence intervals crossed 1, he concluded that there was no difference between G13 and other mutations for cetuximab. This shows that even a collaborator from the same group can reach different conclusions despite having similar data to analyze. The bottom line of the Tejpar paper for clinicians is as followed. Stay tuned. Do not treat patients with KRAS G13 mutations any differently from codon 12 mutations, but you may want to make specific note of what specific mutation your patients harbor in this rapidly changing field. Data from ongoing studies, including the large C80405 trial led by Dr. Alan Vanook at UCSF, may shed further light on this complicated issue. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.